My name's Ian Teague and I'm the Chief Clinical Informations Officer here in Class Professional. I'm here today to talk about ECGs with Mark Ainsworth Smith, or Maz. Maz, would you just introduce yourself?
Yeah, sure. So I'm Mark Ainsworth Smith, but everybody calls me Maz. I'm the consultant. I have been the consultant practitioner for a national ambulance service until the end of October. My background was I worked in accident and emergency for 17 years and then joined the ambulance service and worked for 18 years as the consultant practitioner in one of the large national ambulance services.
Fantastic. Very interesting background. For me, I've been a paramedic since 1992 and a similar length of service, but all my time has been in ambulance service work and my last 25 years in an education role. We're talking about ECGs and there's been a recent health service safety investigation body report on ECGs and paramedics in the UK. They issued a part 1 report earlier in the year, and in October they issued a part 2 of the report. Can you tell me a little bit about ECGs, if you will, and the importance of them in the pre-hospital setting?
Yeah, of course I can, but I think it's really important to start off with by just mentioning the HSSIB report. And unfortunately what they did is they highlighted some concerns that directly led to patient harm as a result of misinterpretation of ECGs. So patients presenting, for example, with chest pain who had an ECG performed and it was deemed that that was normal and that therefore they were okay to stay at home. So the background behind that was the coroner, His Majesty's coroner, issued some prevention of future deaths, also known as Regulation 28, as they're known. And based on that, the HSSIB did an investigation looking at the causes of that. In October, they released the second part of their report, which was, I would suggest, quite critical of ambulance services and around the universities potentially as well, around the preparation for our staff to be able to recognise, interpret ECGs. And so that was really the background driver, and that there will, without any question, be some radical changes as a result of that investigation that's gone through.
Could you just help myself and the audience look at ECG, ST elevation and possibly ischemic heart disease, and how ECG is important to that but can be misleading?
Yes, so obviously anyone presenting with chest pains or indeed other symptoms, shortness of breath for example, or anything along those lines, may well have a 12-lead ECG done. A patient presenting with chest pain who has an abnormal ECG, so in other words ST elevation, that's actually very important information, because in the vast majority of hospitals those patients will be taken directly to cardiac centres, often known as PPCI. It's important that our staff are proficient at recognising ECGs, particularly proficient in recognising ST elevation MRs. But we have to remember that some patients who have heart attacks do not have any changes on their ECG. And I think that's an absolutely key point. There's a couple of reasons for that. One is you can have a non-STEMI, a non-ST elevation MI. But also, we also need to remember that as an ambulance service, we generally get to these patients very quickly. A chest pain comes in as a category 2 call, so generally we'll get there within an 18-minute window. And it's quite common that you don't have any ECG changes at that early stage. And so you could be falsely reassured by seeing a relatively normal ECG and decide that that patient potentially could stay at home. And I think that's something that we need to be really, really cautious about. Where ECGs come into their own, of course, is when we're investigating other causes. So let's set chest pain aside, because chest pains, I think, will generally be conveyed to hospital, and hopefully that will be the case. But if, for example, somebody presents with shortness of breath going up the stairs or falling over for no real explained reason or anything like that, that's where 12-lead ECG can be really, really important. And that's where we're looking for underlying conditions such as dysrhythmias, atrial fibrillation, sometimes other rhythms as well. So it's important that our staff are able to recognise abnormal ECGs. And the key thing there is recognise a normal one. If you can recognise a normal one, it's all around pattern recognition. I've literally looked at thousands and thousands of ECGs over the year. I don't really understand left axis deviation and things like that, but actually, is that important? I recognise a normal ECG, I recognise abnormal, and of course, it's all around pattern recognition.
As you spoke earlier on about some of the common errors, but what is the most common error that you've seen in terms of ECG mistakes or errors for patient care?
So I've seen a combination of errors over the years, really. They range from the auto-diagnostics on the device saying normal ECG when it wasn't the normal ECG. That's obviously really tricky, and I think it is quite easy to be swayed by that, particularly if you're not an expert on ECGs. So that's definitely been something I've seen. The other thing that you can sometimes do is get almost swamped with information. So some of the devices, which are incredibly complex and amazing to use, but they will come up with a whole load of information at the top of the ECG, and it's quite common for that then to be disregarded. So it will say anterior infarct, and you think, well, this is an anterior infarct, but when you look at it, it's almost like there's a swamping of information, and I think people can sort of feel almost like falsely reassured by that. But the most common, and of course this has been picked up by the HSSIB, I noticed in every case that they list there, the patients were presenting with chest pain, and a significant chunk of them were also presenting with vomiting. And I think that's something, sometimes ignore the ECG. That doesn't sound the right thing to do, but actually go with what you're dealing with. If a patient's presenting with chest pain, you can't explain those symptoms, and there are other things such as vomiting, I think you need to be incredibly careful, no matter what the ECG in that initial phase.
Yeah, and of course ECGs is part of a range of clinical diagnostics, from instinct to history to signs and symptoms, and often experience will help you with that. ECG is one of a number of findings.
Henry Dooley is one of the consultants down in the southwest. I remember him saying that 95% of the diagnosis can be made on the history alone. The ECG is the icing on the cake.
And may I ask just a little bit about education and training for ECGs? What's the sort of recommendations that you might have, either when you're starting out or perhaps when you've been in post for a short period of time?
Yeah, so in terms of ECGs, it is around pattern recognition, as we've already said. So it's about seeing as many as you possibly can. And then it's really important as well sometimes to work with experts who really know what they're talking about. In some areas of the country, of course, you can go and do placements on coronary care units, and that's an absolute game changer. When you're working with some of the nurses and doctors that work on the CCUs, you get really good experience, and obviously you get affirmation. So when you see something, you can talk it through with them and discuss it. And I think that's the key one, but it is around numbers. There are obviously, as well as that, some really good supplemental learning packages around, where you can, get copies of ECGs, and there's even some stuff on YouTube. To be fair, there's some pretty good stuff. But actually, having a sort of a formal education in university is really important, and that's probably a bit where the HSSIB are coming in. They're saying that information and that education hasn't been consistent across the board, and I think that's probably what we're going to see as a driver for example, all paramedics to be able to pass an ECG package, some sort of assessment package at the end of their training, so that His Majesty's Coroner can be reassured that everybody's proficient in recognising ECGs. I think it's quite likely that we'll see some pretty radical changes like that.
We talked a little bit about improvements for both training and recognition, but if you had some top tips for paramedics and other emergency services providers, what would they be around ECGs?
So there's basic stuff obviously around placement, so limb placement, etc. There is variation depending on the device as well, so I think it's really important. Start with the basics, make sure you get your landmarks right. Obviously when you're putting your chest leads on, they need to be correctly placed. I think just keep it as simple as is possible, and don't overcomplicate things. Don't be swayed by the auto-diagnostics. Some ambulance services nationally have actually turned that off. I think that's really important actually, because it can give you false sway either way, and don't ignore it if it does come up with a comment. And I think that's really important. I know sometimes you look at it and it's diagnosed an anterior MI, and you're like, oh my gosh, I don't see that at all. But don't ignore it. Weigh that into your factors, and key to this is good documentation as well. Absolutely key that accurate records are kept. And I think the other thing that I always think is go with your gut. If you are, for example, going to leave a patient at home and you're worried about it, then really consider whether that's the right decision to do.
If you were looking back on your career, what advice would you give to yourself around ECGs, knowing what you know now, and perhaps some of the HSSIB reports and investigations you've been involved with? What advice would you give yourself starting out?
So I think having some formal training, but working with experts is absolutely key here. On every ambulance station, there are experts. There are people who are really, really good. And sometimes having a buddy who's really interested in the ECGs, but perhaps not in maternity or other things like that, can be really, really useful. And certainly I learned probably 90% of what I know about ECGs from working alongside colleagues and them explaining it to me in a way that I could actually understand it. So I think that for me is a key thing.
Thanks very much for that great interview. I'd like to just talk a little bit about the books that are available from class that will help you with ECGs. So ECGs on the Go is a great start out when you're a student paramedic and gives you some great cue cards in order to practice ECGs, but they are great for existing experienced staff as well. And a more detailed textbook is the Clinical ECGs in Paramedic Practice. Again, another way of improving and continuing to practice the ECG recognition. There is another book that's being produced and will be released in 2026. And don't forget that the class Parapass CPD app will be a great place to practice both the clinical presentations and ECGs.